When we think in terms of prolonged pregnancy, we need to consider what is the gestational age of the patient's baby. Induction only if vaginal delivery is appropriate should be the tagline or the red letter line which we need to follow in practice, because we are inducing only on the basis of thinking that this patient is going to have a vaginal delivery. What do we do? Pregnancy uncomplicated, pregnancy complicated. So you would think in terms of doing an induction at 40 plus weeks. We will go into the controversy a little later, and at around 39-40, what we will do is we will offer them a membrane sweep, and we will definitely think about induction of labor after 41 weeks. But this talk, what I'm going to do now, will change in the couple of few slides, because we have moved away from 40, 41 to between 39 and 40. So we will see why the transition and how it is. Pregnancy complicated, assess best timing for delivery, offer membrane sweep and induction at appropriate time. What I mean by that, for example, if a patient is having very high-grade hypertensive disorder of pregnancy with preeclampsia, proteinuria, whatever, she's only 34-35, be very happy that you've reached 34-35, and then you can probably think in terms of delivering her at that point of time if the parameters of preeclampsia go in. At that point of time, you would assess the best timing for delivery, and then you'd offer them a membrane sweep and induce even if she's 34-35, etc. and not wait for 40. So a certain gestational age, not all women will respond to intervention in the same way. For example, if you induce them with a prostaglandin gel, one of the patients may require 2 gels, another will require 3 gels, and one may deliver even with one particular gel. So it may not respond in the same way as every particular patient. You need to understand what is the proximity to spontaneous labor, whether you're inducing at 39 or 40. And we also need to take into consideration the parity of the lady, because a second gravida or a third gravida would probably respond much better to inducing agents and your induction strategies much better than a primigravida. Keep in mind the Bishop score, and the more favorable the Bishop score, easy would be the induction of labor to delivery time, and we will discuss that also. The so-called Bishop score, I'm sure all of you will be aware of the Bishop score, and you would go on and say dilatation, effacement, station, consistency, position in the older criteria. And in the modified Bishop score, you will say dilatation, length of the cervix, station, consistency and position. And here the scores are little different from what it was in the previous old Bishop score. So in the modified Bishop score, you would put this particular criteria. So I've just put both together up and down for you to compare.